Welcome to this webinar on Prehabilitation in Emergency Surgery, the role of ERAS in the acute setting, which is brought to you by ESTES, the European Society for Trauma and Emergency Surgery. We want to make this webinar as interactive as possible, so please ask any questions as we go along through the Q&A button. We will try to answer them during the webinar, either directly with a written reply or as part of the panel discussions. If there are a number of similar questions, we may answer them together. And if you ask a great question that we don't have time to answer during the webinar, we may send you a reply by email afterwards. There will be a couple of case presentations and a number of interactive polls during them. All voting will be anonymous, so please don't be reluctant to take part. We'd love to know what you think, but we won't be able to tell your colleagues or your boss. We have three great international panelists who, in order of presentation, are Professor Jose Manuel Ramírez from Zaragoza in Spain, who is president of the Spanish Multimodal Rehabilitation Group, as well as guidelines. His publications on ERAS range from its application to colorectal surgery and elective orthopedics. Dr. Raul Coimbra is an internationally recognized trauma surgeon from the United States who specializes in trauma, surgical critical care, and acute care surgery. Shahin Mohseni is Associate Professor of Surgery at the University of Orebro in Sweden and is currently chairing an international consensus group developing guidelines for ERAS in emergency laparotomy. I'll now hand over to my co-moderator to introduce himself and to present the first case. Aitor, over to you. So if you can share your screen and unmute your microphone.
Okay. Good afternoon. I am very happy to be as collaborator in the first webinar about rehabilitation. This is our clinical case. This is Monday, 2 a.m. We are on call. We are very tired, and the pager sounds. We have a 65-year-old man with severe upper abdominal radiated towards right shoulder. BP and heart rate is normal. No feverish, and clinical findings are belly acute abdomen.
Can you share your presentation? Can you share your screen?
No, okay. Now?
Okay.
Yes, okay, sorry. This is the clinical case. This is Monday, 2 a.m. We have a woman, 65 years old, with severe upper abdominal pain radiated towards right shoulder. BP and heart rate are normal, and abdominal finding is belly acute abdomen. And now we have the first poll, isn't it?
You have a CT scan?
Okay. This is CT scans, and we have here anterior gastric wall.
Okay, go for the first poll then. So the question for you is, the first poll is, what's the diagnosis? You have a choice of acute pancreatitis, a ruptured splenic artery aneurysm, perforated peptic ulcer, perforated sigmoid diverticulum, or acute cholecystitis. So if you want to vote now. The second question, how would you manage this patient? With emergency surgery, with analgesia, antibiotics, intravenous saline, schedule urgent surgery during working hours, or neither of those? Third question, what's the predictive operative mortality for a 65-year-old female with a perforated peptic ulcer, normal physiology and no comorbidities? And according to data from the Danish Clinical Register of Emergency Surgery, every hour of delay from admission to surgery for perforated peptic ulcer is associated with a decreased probability of survival compared with the previous hour of. You have a choice of 0.4%, 1.4, 2.4, 3.4, 4.4, or don't know. And in the light of that, would you like to change your answer to question 2? How would you manage the patient? And the final question for this session, you decide to operate. It's 2 a.m. How long would it usually take to get the patient to theatre and make the first incision in your hospital? Is it less than 30 minutes, 30 minutes to 1 hour, 1 to 2 hours, or more than 2 hours? Okay, so we'll end the polling there because I think most people who are going to vote have voted. And these are the results. The later questions were a bit of a giveaway that the diagnosis was a perforated peptic ulcer. How would you manage the patient? 76% would go for immediate surgery. 17% would go for analgesia, antibiotics, intravenous saline, and schedule an urgent procedure during working hours. And 3% would do something different. So I'm going to ask the panel, what do you think about that? Dr. Coimbra.
I think 65-year-old female with perforated peptic ulcer and rigid abdomen, physiologically stable, I would take that window of opportunity and go immediately to the operating room.
Okay. Anybody disagree with that? Okay, we'll move on. Predicted mortality for this woman, for this individual patient. If you do a P-possum score, then actually it is 1.7%. So her predicted mortality will be in that 1.6 to 2.0, which is where 17% of the audience put her. And according to the data from the Danish Clinical Register of Emergency Surgery, every hour of delay from admission to surgery for a perforated peptic ulcer is associated with a decreased probability of survival compared with the previous hour of, the correct answer is 2.4%, which is where 21% of the audience were. Okay. And in the light of that, a few people wanted to change their decision, and unfortunately, we don't know whether that was to go immediately to theatre or to delay, but that may become more apparent later on. But most people made their choice and stuck with it. And in most cases, it will take between 1 to 2 hours to actually get the patient into theatre once you've made the decision. Okay, let's carry on with the next.
Okay.
Carry on with the case.
This is the perforation of the anterior abdominal wall, and this is the free liquid insuhepatic region. Then we decided to operate. We phoned to the anesthesiology, and the anesthesiology is so tired like us, but with belly acute abdomen, we decided to go as soon as possible to the operation Ciota. In the operation Ciota, the anesthesiologist asked us about if we want antibiotics. Oh yes, amoxicillin. I forgot it in the hurry. In meantime, we are thinking about what will be the best approach to perform the surgery. Maybe a small incision can be good for the patient. It's not clear in the guidelines if a laparoscopic or open approach. Then we decided to perform a small incision, supraumbilical incision, to suture the whole Graham patch, biopsy, and to put a drainage. Okay, and this is the pool now.
Okay, so we've got a second poll for you. Question, how would you do this procedure? You have a patient with a perforated peptic ulcer. Would you perform it open or laparoscopically? Would you use a nasogastric tube? Would you use an abdominal drain? Okay, we'll stop the polling there. And most people, 73%, would do this laparoscopically. Most people put in a nasogastric tube, and majority of people would put in an abdominal drain. Okay, we will think about those results as we go on. Okay, we'll carry on with the case.
This is the post-operative. We remove the nasogastric tube 3 days after the surgery. We start the intake at the 4th day, only with water, and we increase the diet day by day, and we only have a problem with a wound infection, and this was the cause to discharge at the 10th day. And this is the pool again.
Okay. So we know the case. What's the predicted post-operative morbidity for this patient? Would you expect less than 10%, between 10 to 20, 21 to 30, 30 to 40, or 40 to 50? And the second question for you, in your experience, is this a common scenario? Okay, end the voting there at that point. Panel, what do we think the post-operative morbidity of this patient might be? Shahin, do you want to?
What I'm missing is her comorbidities and her frailty scoring, but it's low. It's less than 10% if you get her to the OR very fast, give the antibiotic, and do the surgery laparoscopically. I would say it's less than 10% for morbidity.
Okay.
Mortality, I haven't had any mortality cases on my own here in Sweden for perforated ulcer, so we are doing something correctly over here.
Okay. Professor Ramírez, what would you say the morbidity would be expected in this patient?
It's a very, very, very good question, because perhaps using laparoscopy surgery in this case, especially this case, we will decrease the morbidity, because it's the infection, or bone infection is the morbidity in this case. Mm-hmm. So we should stress in this case to use laparoscopy surgery in order to avoid high rate of morbidity, and less than 10% for sure. Other case is mortality, which is should be less than 1% in this case. I mean, 65 years. So please, laparoscopy surgery in such cases. Other question is to use drains in abdominal emergency. Yeah, I have to discuss the point.
Yeah, we'll discuss that as we go on. Dr. Coimbra, what would you say the risk of morbidity or the likelihood of morbidity in this patient is?
So before I answer that question, I would just want to make a brief comment. We are just assuming this is a peptic ulcer disease, but in a 65-year-old female, it could be cancer.
Yeah.
So I think the strategy depends on the diagnosis. I would probably start with the laparoscope, and if I have a higher index of suspicion this is cancer, I would convert to open to do a definitive operation if the local conditions would allow me to. So that's comment number one. And I think that to answer your question, it depends if you need to convert or not. Mm-hmm. But if you consider overall comorbidities, including ventilator-associated pneumonia, DVT, UTI, and all that stuff, it's probably around 10 to 15%.
Okay. I put the data through into PPOSM scoring, and the predicted morbidity remarkably came out at 39.2% for this individual. So it's much, much higher than we think. But 6% of the audience were with us on that one. Okay, most people think this is a common scenario, which is good. Okay. So we have got to the end of the case. I hope that's given you something to think about. Professor Ramírez, can I ask you to give your presentation, please? If you share your screen.
Absolutely. We're trying to show my screen, just my PowerPoint. Please let me know if you see my PowerPoint presentation. That's fine?
Perfect.
You see only the presentation, that's right?
Yeah.
Okay, so it's a pleasure. It's a pleasure to be in this debate. So many thanks to the organizers. So my name again is Jose Ramírez. I am professor of surgery at the University of Zaragoza. I'm also the chairman of the Spanish Society of Multimodal Rehabilitation. So in order to focus the topic, it's just, could you have a look to this graphic, please? So more than 300 surgical procedures are performed worldwide each year. More than 4 million people worldwide die within 30 days. So this number is the post-operative death, the third commonest cause of death in the world. In the 90s, Henry Kellett proposed protocols to reduce surgical aggression in order to minimize morbidity and complication. So nowadays, these protocols are known as ERAS protocols. Since Kellett, journals has been filled with publication telling us the benefits of ERAS protocols in practically all areas of surgery, but none or very few in urgent surgery, most of them elective surgery. In 2008, the Spanish Multimodal Rehabilitation Group was born. The main aim was to adapt the so-called ERAS protocols to our healthcare system. We were a very small group of surgeons, anesthesiologists, and nurses from 9 Spanish hospitals. This is our first publication, our first paper. We published the paper 2 years later. And we saw that using ERAS protocol, we were able to reduce hospital stay by 6 days. But what was perhaps more relevant was the fact that when treating our patients, we were treating our patient in a protocol and we were treating our patient in a similar way. So reducing disparity, hence increasing safety and quality of care. After this paper, we started working with our national health system and ministry, and in 2015, we published, we edited in a joint activity, the Spanish Enhanced Recovery for Abdominal Surgical Clinical Pathway. So they call in Spain via RICA. It is a review of nearly 100 items of the Pre-Operative. You can download this via RICA from our website. By then, we were more than 500 members. These members were split in working groups according to the different areas of interest. These areas, as you can see here, and the idea is to generate practical, easy to use protocols from the recommendation of the clinical pathway. One of those groups was the emergency surgery group. One question in those days: could ERAS protocol be used in the urgent surgical patient? We're talking about 2015, and since then we are working in emergency and how emergencies could be served. So in this slide, I show you all the members. Is 29 people involved in this group, in this subject, working together in order to give us some answer to the question. They published some protocols in 2014 about colon, perforation and occlusion, in 2016, cholecystitis, and you can also download this protocol from our website. But also, we had publication. This is a publication when we analyzed enhanced recovery programs in left colon perforation. Conclusion: ERAS protocols are feasible and help to reduce morbidity and length of hospital stay. Lastly, I want to present this paper, published last month in our surgical journal, Cirugía Española. The conclusion in this paper is, whatever the setting, it is worth to implement as many ERAS items as possible. And this is a cornerstone point. It is not a question of to whether or not to have an ERAS protocol. It's a question of guideline recommendation. So you should tailor the recommendation to any particular case, being urgent or not. What about the subject of the debate? Prehabilitation in the emergency surgery. This is a very exciting point. Let me know how much time do we have to do prehabilitation. Another question is, what kind of surgery, urgent surgery are we talking about? Which procedure are we talking about? Because emergency surgery are many procedures. So we should divide each case, individualize and tailor our protocol to such individual procedures. And this is the best I can say. So I am open to discussion with our panelists. Thank you very much.
Thank you for that great presentation. One of the things that the audience in general reported was that at 2 o'clock in the morning, if they decided to take the patient to theatre immediately, they would still have between 1 and 2 hours before they actually got their first surgical incision. As you say, you do as much as possible within that time. What in a list of priorities, what would you prioritize and do first from your list of potential ERAS interventions?
That's a very, very good question. Fluids. So we had to have in mind that to reduce fluids, the administration of fluids and liquids and so on is very much important. And then pain. You should control pain. So the paper of anesthesiologists start 2 hours before surgery, just not in the theater. They have to have a look to the patient, have a look to the fluids of the patient and think about how much fluids, and goal-directed fluidotherapy is the name. So goal-directed fluidotherapy is a main cornerstone in these patients, and then how to treat in a multimodal process the pain of the patient and so on. That's very important. Of course, you should use antibiotics and so on.
Okay, so those are your...
if you can, you should use laparoscopic surgery, because now we have a very last month there is a paper telling us that in most cases you can use laparoscopic surgery without any problem for patients. So this is a point, an item: fluids, laparoscopic surgery, and paper.
Okay, Dr. Coimbra, what would you do in that 1 to 2 hour window that you have before this patient gets to theatre?
Yeah, so I think that the most important thing is to have a rapid and as complete as possible assessment of the physiology of the patient and physiological derangements, get all the labs, make sure that if you're dealing with something that involves infection, to me, early antibiotic therapy is of utmost importance. Gentle fluid resuscitation guided by physiologic parameters with sort of a goal directed, as Professor Ramírez mentioned. And make sure that we have a good assessment of acid base and coagulopathy as well.
Okay, great. Dr. Mohseni, what would you do? Anything different?
Actually, I think all the answers is given. Assess the patient's risk for post-operative complication. Have the senior anesthesiology or critical care on board early on to help with the if the patient is deranged in his physiology, have him to OR fast enough, and as mentioned, antibiotics early on.
Okay, thank you. So within that 1 to 2 hour period that most people seem to have, even if they decide to take the patient immediately to theatre, there are a number of things that can be done which will improve the outcome. Okay, Dr. Coimbra, are you ready to do your presentation?
Certainly.
Thank you.
Thank you. All right, so Jonathan, the team, thank you so much for the invitations. It's really a pleasure for me to join you here in the morning and late in the evening in Europe. You asked me to talk about the situation of ERAS in emergency general surgery in the United States, and certainly of the 3 panelists and the several members participating today. I am probably the least experienced to talk about this because this has been work in progress in elective surgery in a number of specialties, but hasn't been the focus of EGS as it stands in other parts of the world. However, I think that the reason for that is that a number of the measures or components of ERAS in any surgical disease are already part of a number of our checklists. You know, remember that most of us that are trauma emergency general surgeons in the US, we are surgical intensivists. So some of those things that are part of the ERAS are already part of our resuscitation protocols in the ER. Some are part of our intraoperative resuscitation strategies, and some are part of our post-operative ICU protocol. So we may not call it ERAS, although we should, but they are already part of our resuscitation, our treatment strategies in different phases of care. You know, maybe some of the members on this panel are co-authors or authors of some of the papers that I'm going to present, but this is the most recent meta-analysis I could find published in the World Journal of Medicine, looking at the ERAS protocols in emergency abdominal surgery. And as you can see, very recent publication, there are 6 papers. I know that Mauro Zago was part of one paper that looked at 4 of these 6 papers in a previous review. But when you look at the total number of patients in each of these trials, the number is actually really, really small. So this is something that has not caught up as much as ERAS has caught up with other surgical specialties, particularly elective surgery in many different fields. So it strikes me that we are not there yet anywhere in the world. That's number one. Number two, the challenges are that there are so many components in this package. I call ERAS a package because it's nothing but a package or a long checklist. And if you look at across the 6 studies presented in this meta-analysis, there are a number of components that are very difficult to implement in emergency general surgery. And that brings the question, what is it that we are talking about? What is it, emergency surgery? How do we define emergency surgery? If you look at the burden of disease, there are about 10 diagnoses that encompasses 95% of all emergency surgery that we do in our current practice all over the world. So there's about 10 diseases that we take care of. And the question is, how do we bring this package to all of them, not just to laparotomy or to colon surgery or to gallbladder surgery, but to all emergency surgery? Because some of these things are really important to be widespread throughout the whole spectrum of surgical practice in acute care surgery. But for instance, pre-operative counseling, well, if you have pre-operative counseling for 2 minutes, is that valid compared to elective practice? So that's questionable. Some of those studies didn't mention the importance of preoperative fasting and carbohydrate loading. Is this feasible in emergency surgery when you need to take people immediately to the operating room? Some of this data is hard to interpret because out of 6 studies, 4 didn't mention even thromboprophylaxis, which is one of the most common post-operative complications in abdominal surgery. Antibiotic prophylaxis, which is the most important and evident measure one can take when you're dealing with acute abdomen and other acute care, other emergency general surgery conditions such as soft tissue infection and perirectal disease, etc., are not even mentioned in 4 of the 6 studies. Maintenance of intraoperative normothermia, not even mentioned in 2 of those studies. So what I'm trying to say here is that we have not reached consensus of what is doable. We know what's important, but we don't know how to operationalize the implementation of what's important to make it doable to this patient population that we have yet to define better. And then we need to package this like we've packaged trauma guidelines and elective surgery guidelines to make sure that this checklist is followed accordingly. So I still think that we are, at least in the United States, but I can read the data from other places in the world, we are trying to do this in pieces. And I actually would like to propose a different view, that we don't do this in pieces, but we do this as part of a program that would be the emergency general surgery program of hospitals. And like we have trauma centers, we would have emergency general surgery centers that embrace those guidelines, like we embrace the ATLS guidelines for trauma care. And then, only then, I think the implementation of ERAS will be widespread. If you look at the 6 studies, again, only 1,300 patients were eligible, and look at the important results. Less time to first flatus, less time to first defecation, less time to first oral liquid diet, to oral solid diet, and some evidence that length of stay decreases. Well, these are important events in the post-operative period, but I would not call at least 5 of this really outcome measures. These are events, but not outcome measures. The only outcome measure that was positive here was length of hospital stay. Now, there is a lower risk of total complications, major complications, pulmonary, ileus, and surgical site infection, and those are important outcomes. Unfortunately, with or without ERAS, none of the 6 studies were able to demonstrate a significant decrease in 30-day mortality, need for readmission, and need for reoperation, which are really, really important outcome measures. So again, some evidence that this will work, but not a lot of evidence that this will really affect what's important for surgeons and for patients, which is 30-day mortality or 60 or 90-day mortality, need for readmission, and need for reoperation. So we still need to accumulate more data, be a little more open-minded to a broader dissemination of this, instead of picking an operation or a disease and say, okay, now I'm going to do ERAS for acute cholecystitis. Because to be honest, if you follow the basic principles of surgery, acute cholecystitis is deemed a very low risk disease, and the operation, laparoscopic cholecystectomy, is deemed a very low risk operation. So we need to really think more broadly in terms of what is emergency general surgery that we want to act upon implementing this ERA guidelines. So here are the components. So I put a question mark on the side of each one that is probably not feasible, although it's listed in these papers as appropriate. So pre-operative education and counseling, well, sometimes I have half an hour to talk to the patient before I go to the operating room. Sometimes I don't. Pre-operative medical optimization, what does that mean? In the emergency setting, you know, you have, as you mentioned, an hour, maybe two at most, to optimize physiology as much as you can. Bowel preparation is definitely not appropriate, at least for the emergency general surgery patients that I take care of. Pre-operative carbohydrate drinks, no overnight fasting, this is all good for elective surgery, but I question how can we do this for emergency surgery? Volume excess, yes. Avoidance, good. Long-acting pre-anesthetic medications, as Professor Ramírez mentioned, treating pain early, very important. Then obviously all the other ones are appropriate, including treatment of nausea, vomiting, avoiding NG tube, prolonged use of NG tubes, and good pain management. Laparoscopic when possible, not always possible. There are other diseases that are not in the abdomen, so we should not limit ourselves to sponsoring one technique when we may not use that technique for 2 or 3 other emergency general surgery diseases. And obviously mobilization. I am missing here the thromboprophylaxis that I'm so attached to, because I've seen so many emergency general surgery patients and trauma patients develop DVTs and pulmonary embolism. So I think we can actually expand the list from the elective setting to the emergency general surgery setting. So here, intraoperative volume resuscitation guided by endpoints. I think it's a component that needs a little more detail. We need to flush out this better. Not all cases are the same. So just saying, well, we are going to try to avoid giving a lot of fluids is great, but how do you do that? We need to flush those ideas out. We need to create those algorithms so people can embrace this, so they don't have to think about developing their own guideline or their own algorithm. It is our responsibility to then, as a professional organization, to work collaboratively and develop those algorithms for them. There is no mention of acidosis, sepsis, hemorrhage, ischemia, and coagulopathy compensation or preventive measures, and I think those are very important in the emergency setting. Temperature control, avoiding hypothermia is also very important, not mentioned in those papers that I just described to you. Control of hyperglycemia intraoperatively is also very important in some emergency general surgery circumstances, particularly those associated with a higher risk of mortality in diabetic patients, peritonitis, significant infections, soft tissue infections, Fournier's gangrene, etc. Short-term use of antibiotics when feasible. I think this is very important. You want to give it early, and you want to stop as early as possible. And I think we need to develop the guidelines to do so. I would recommend that folks, at least for now, that those guidelines are still being discussed, that read the Stop It trial published in New England Journal of Medicine in 2012, that we participate in and propose that most acute abdomen conditions, antibiotics could be stopped by day 5 without any increase in morbidity or mortality post-operatively. And again, DVT prophylaxis is not included in most studies and should be part of this package. So to answer the initial question, are there impediments for implementation in the United States? Really, there are no impediments. The problems are those that I just described. The definition of EGS based on the burden of disease is important, and we need to look at that 10 disease list and see if we can create a package that is appropriate for all of them, not just for 3 or 4 of them. The package is incomplete as it stands because just trying to adapt what we do in elective surgery to emergency surgery may not be the best strategy. And in my opinion, the package must be redesigned. Most components exist already, but they need to be measured by other quality improvement initiatives in the hospital as well. So as I said, a lot of these things we do in the ICU and we measure them every day, we just don't call it ERAS. Components are nothing more than quality indicators, so we need to measure them in all phases of care and follow their trend. I think that this will be successful and effective when it's part of a continuous quality improvement process. If we don't have a programmatic approach to this, I think that this will be done by isolated hospitals in different parts of the world, but not as a sort of a mandatory approach to emergency general surgery as it should be. In the US, to that end, the American College of Surgeons is launching an emergency general surgery verification program for hospitals, which include all those metrics. And we believe that using this as part of a program will give us a potential to show improvements in mortality, readmission, and an expected return to the operating room. Thank you for your attention.
Thank you, Dr. Coimbra, for a very interesting, thought-provoking presentation. I'm tempted to not have any discussion at this point, but to go on to the next presentation from Dr. Mohseni, who will be telling us about exactly how you can use ERAS in laparotomy and emergency surgery.
Thank you, Dr. Tilsed. Can you see my screen? Is my screen on?
Not at the moment.
Okay. Let's try again.
Perfect.
Okay, there we go. I would like to start by thanking the ESTES for giving me the opportunity to present here today. So it has already been established that emergency laparotomy is a fraction of what we do in emergency surgery all over the world, but they are associated with high rate of morbidity and mortality post-operatively. And when it comes to these cases, patients that are subjected to emergency laparotomy, they often present with a physiological derangement. They are often older and burdened by several comorbidities, which we have to take into account. And there's another difference between the emergency laparotomy and elective laparotomy. This is the lack of time to optimize the patient, and they tend to come in mostly during the night when the best team is not available and there is other things going on in the hospital that obviously takes time from these patients. During the last decades, the ERAS Society has put out several clinical guidelines in elective surgery, which have led to decrease hospital length of stay, morbidity, in some cases mortality, and increase the patient satisfaction when implemented and adhered to. More and more data is coming out where centers have produced their own ERAS protocols in emergency surgery and especially in emergency laparotomy. Under the lead of Dr. Peden and Scott, the ERAS Society had put a group of clinicians to write the guidelines for pre-operative care of emergency laparotomy. And I'm going to present some of the aspects from it today. the essence of all of these guidelines is that they should be evidence-based, they should be multidisciplinary and including the patients. And the guidelines are for the whole preoperative care. And data from the ERAS studies have shown that if centers do the right thing, both in the preoperative, intraoperative, and postoperative period, adhering to the guidelines, then they show the best outcomes. So adhering to the whole surgical journey of the patient is important. But for the sake of this talk, I'm gonna concentrate on the preoperative period. As mentioned, the goal is to have an early investigation and diagnosis in patients that are presenting with acute abdomen and are gonna be subjected to an emergency laparotomy, but at the same time, correct the physiology of the patient. One important aspect that the ERAS guidelines are gonna have is to have an early estimation of patients' mortality risk. Studies have shown that in UK, when patients have had their perioperative risk estimated early on, then the senior consultants have been involved in patient care. They have been admitted to ICU more often. So basically, they have had better care. And when it comes to patients that are 65 years of age or older, assessing their frailty is also important, since we know that just age is not representative for the postoperative adverse outcomes. Another aspect that ERAS protocols are going to include is early assessment of the neurocognitive function. We know that patients that develop delirium postoperatively have seriously bad outcomes. And here, there's much to do. Studies shows that we can decrease the incidence of delirium by implementing early on protocols like following the Beers protocol for what medication anesthesiologists use. And then early involvement of geriatrician has also shown to be decreasing adverse outcomes postoperatively. Another essential point of the ERAS component for the emergency laparotomy is early recognition of sepsis and treatment. Up to 40% of patients that have been subjected to an explorative laparotomy had an ongoing sepsis or were in septic shock. In a study, NCOPD study from 2015, they noticed that only 60% of these patients actually receive sepsis protocol-driven care. So assessing this patient early on and implementing the sepsis protocol with one of the paramount important things are that early antibiotics early on. And then we come to the diagnosis. Early diagnosis, and when it comes to acute abdominal pathology, CT is absolutely the most important thing. It's also very important to have the patient as soon as possible to the operating room. And the ERAS guidelines recommendation will be that if the patient is septic shock, they should be in the OR and started operating within 3 hours. And another thing is that a consultant or attending surgeon and anesthesiologist should be present at the start of operation, which is not always the case, at least here in Europe. Another point is that an early assessment and involvement of critical care specialists is recommended, and the patient should always be admitted to ICU. Obviously, this is not a problem in the United States, where most of the surgeons that take care of these patients are critically care trained, but most of places, at least in Scandinavia, there's a need for them to be involved early on. So is there any data behind this recommendation? LP Quick, which was part of the NILA group, put out together a bundle a couple of years ago, which had the early assessment and resuscitation, early antibiotics within 1 hour if there is evidence of sepsis, prompt diagnosis with a CT scan, and having the patient to OR as early as possible with senior attending or consultant present, and admitting all patients to ICU afterwards. When they compared 4 centers before implementing the LP Quick and after implementation of the LP Quick, they noticed that 6 lives per 100 could be saved. And more interesting was the reduction in mortality in patients 75 years and older. There they could see the real change. And this is probably because these patients were more frail. Finally, as everything else in surgery, and shown by our ESTES snapshot study that looked at the cholecystitis and index cholecystectomy, even if all the centers knew the best practice and they reported that they adhered to them, only 50% did an acute cholecystectomy on the index admission. And that's the same thing with the ERAS protocol. What we think we do or what we say we do is not necessarily what we actually do. So it's not just implementing, it's adhering to all the elements in the guidelines. With that, I want to thank you for this opportunity and answer any questions. Thank you.
Okay, thank you, Shahin. Could you stop sharing your screen?
I'm trying, sir.
Okay, never mind. We've heard a lot from all the panelists this evening about having goal-directed fluid therapy. We've also heard that the patients are different. Some of those are acidotic, some of those are coagulopathic. So as a question for all of the panelists, what goals would you specifically look at in your goal-directed fluid therapy? And I'm going to start with Dr. Coimbra because he's next to me on my screen at the moment.
Yeah, so I think having a preoperative assessment of renal function and GFR is important. A lot of these patients come to the hospital, they are dehydrated, they are dry already, and we want to make them even drier. And we give them a load of contrast and we worsen their renal function during CT. So I think having a good assessment of renal function is important. And what I followed for perfusion is lactate clearance. So I get a lactate as soon as they hit the door. If it's going to be an hour or two between admission and the operation, I get a second lactate because I should have resuscitated them during that period. And then I communicate with the anesthesiology during the case, depending on the duration of the case, and we get another one intraoperatively and definitely one on arrival to the ICU. So in a short period of time, maybe 4 or 5 hours, you have 3 or 4 lactate values that will give you an idea of clearance, if you're moving the right direction or not.
Okay, Professor Ramírez, would you use lactate or something different? And there's also the importance of not taking a dry patient to theatre. How does that sit with your minimum amount of intravenous fluids?
Well, thank you very much for the question. I couldn't agree more than with Professor Coimbra. Thank you. Yes, lactate is is the best to measure about hydration of the patients in this way. So please have a good look to the renal function, to the creatinine and so on. The other question is, when you are in the theater, talk with your anesthesiologist in order to balance with there are some special devices you can use in the theater for measuring the ejection volume and so on. So perhaps a Doppler guide, perhaps you can use this in order to have a needle balance, because it's good to have a good hydration, but it's perhaps bad to have a hyperhydration of the patients at home. So the best is just to balance the hydration of the patients. Thank you very much.
Okay, Dr. Mohseni, would you add anything to lactate and intraoperative Doppler?
Actually, the guidelines that we are putting together right now is stating that lactate should be taken and followed during the whole process. Was that the answer to your question?
Would you add anything else? We've had lactate, we've had what I presume is transesophageal Doppler. Would you use anything else in addition to that for your guided fluid therapy?
No, I wouldn't. And there's actually, we had looked at the data for the guidelines, and fluid therapy was actually the one that there is least evidence-based data on how to manage that.
Okay. I'll ask another question that we've had. Are there any candidates who would not be suitable for ERAS? Any patients that would not be suitable candidates?
So perhaps it's just a question of mind. It's just no ERAS protocol or no ERAS protocol, as I said in the last of my slides. It's a concept of items. It's a concept of recommendation. How many recommendations can you use in your patients, in this particular patient? So how many items? It's just like Professor Coimbra said, it's a lot of items, and some these items, I can use this in a urgent setting, but I can use some. As many as you can use, the better for the patient.
Any of the panelists want to comment on the presentations that we've had? Okay, and what we'll do is we'll move on to Aitor for your second case presentation, just to wrap this up. If you can share your screen with us.
Why not? Ah, sí. Bueno, I am happy because we get to stimulate the audience, which answer about ERAS. Then this is our second case. This is the same case. This is Monday, 2 a.m. We have a woman, 65 years old, with severe upper abdominal pain radiated towards right shoulders, with very acute abdomen and with perforation in anterior wall and with free liquid in subehepatic region. But we decided to operate, but we can do something more before to operate. This is broad spectrum antibiotic as soon as we have the diagnosis. And this is according to the society guidelines, according to the local availabilities, but we have to put as soon as possible antibiotics. It's very important to start with proton pump inhibitors in the preoperative stage, because the proton pump inhibitors can sell the hole or can stimulate the cicatrization of the ulcer. It's very, very important to avoid the body temperature losing. It's very important to try to put a blanket. If we have an active blanket, is better, but if we don't have this, which a blanket is better to the patients to avoid the temperature losing, because mainly in elderly patients, this is very important. It's very important to avoid such effects as blood coagulopathy, cardiac events, and surgical wound infection. It's very important a mechanical compression measure, which soccers, and most of the experts in gastric surgery say that it's very important to place a nasogastric tube to avoid the gastric atony, to avoid the continual swelling of acid, biliary or pancreatic liquid. This is in the, then we can do some things before the surgery without lose a lot of time. In the intraoperative period, it's very important to avoid fluids. Why? Because we can cause edema in the tissues, and this is very bad for the post-operative period. And this is very important to control body temperature with active warm blankets, to control pain, which blockage, with epidural catheter, with some things that this can be according to the laparotomy or the laparoscopy, according to the localization of the incision. But we have to avoid morphine drugs because they are very bad for the patients. We can't to remove or not to put a Foley catheter. It's very important laparoscopy approach in this case because WISES guidelines recommended to use laparoscopy approach mainly in case like Graham patch or vagotomy cases. And drainage in diffuse peritonitis, they are a very important study, a Japanese study with 4,000 patients, and they conclude that in diffuse peritonitis is better a drainage than not a drainage to avoid complication, which significant dates which P and which the difference between the complication between drainage or not drainage. And in postoperative period is very important, control the pain, prevention of nausea, vomitus, early remove of nasogastric tube. This is 2 days before the surgery, after the surgery, early intake, early mobilization, respiratory exercise, and as Dr. Coimbra says, it's very important to do a short antibiotic treatment. This is which control with C reactive protein value to avoid the large antibiotic treatment that most of the guidelines demonstrate that is not necessary, which 3 or 5 days is enough to control the focus of the infection. And this is time for the pool, I think. No? Yes.
We'll ask another poll. You may notice it's a little bit similar to one we had earlier on. How would you manage this patient with immediate surgery, analgesia, antibiotics, intravenous saline schedule, urgent surgery during working hours, or neither of the above? Would you perform this procedure open or laparoscopically? Would you use a nasogastric tube? Would you use an abdominal drain? Okay. Well, and on this occasion, the number of patients, or the percentage of the audience that would go for emergency surgery has gone up quite considerably to 83%. Most people would do this laparoscopically. Most people would give pass a nasogastric tube. And although the majority of people would use an abdominal drain, that seems to have reduced a bit from where we were before. Okay. I also want to give you another poll about ERAS in emergency surgery. And this is a very straightforward poll. Do you use ERAS in emergency surgery? Do you not use it? Do you use a few of the measures we've discussed? Do you use most of the measures we've discussed, or do you use all of the measures that we've discussed this evening? Okay, and the results of those, the good thing is that most of the audience use most of the measures that we've discussed this evening, which is good. Although 14% of people do not use ERAS in emergency surgery. Would the panelists like to comment on that? And on this occasion, let's start with Dr. Mohseni first.
Could you repeat the question, please?
Yes, the experience of the audience this evening is that the majority of them will use most of the measures discussed. About 60%, 30% will use a few, but 15% don't use ERAS in emergency surgery. Do you want to comment on that?
Yes. First of all, is the definition of what is the emergency surgery? Is it the APIs and COLIs they're talking about, or the explorative laparotomy? And from the data from UK, is basically that most of the important ERAS protocol-driven care is not adhered to before they actually implement the ERAS protocol. So basically, when looking at how many patients did get antibiotics within the first hours, the NILA group could see that without an implementation of the ERAS protocol, it was actually given too late. So my question is, what is the emergency surgery they are referring to, and what are the measures they are thinking or believing that they are adhering to? I think for most of us, when there is no protocol in place and no involvement of senior colleagues early on in those systems that they are not in-house, all the measures or most of the measures that we know we should do, we don't actually do them.
Okay, Professor Ramírez, do you want to comment on that final poll?
Yes, thank you very much. Because I as I said before, I think there are some people, some physicians, some surgeons and anesthesiologists that they think, they believe they are not using ERAS, but they are using many components of the recommendation of the ERAS protocols. So they say, I'm not using ERAS. And I will say, perhaps you are using many components of ERAS that are normal in the practical clinical in a surgery, in a theater. So perhaps you are not aware that you are using ERAS and you believe you don't. That's my real question.
Okay, Dr. Coimbra, would you like to comment?
Yes, Dr. Tilsed, thank you. I think I agree. You know, Shahin brings up a very important point that I always, when people ask me, what's the next level of quality improvement in a hospital, I say is to measure consistency. And the only question you need to ask is how often you do what you say you do. How often you put your actions where your mouth is, because we talk a lot about many things, but we rarely follow through, and we are not very good at following guidelines as a medical profession, as surgeons. So I think it's Professor Ramírez is correct that we all collectively probably do this more often than we think we do. We may not call this ERAS, we may call it something else or call it nothing, but those measures are common in clinical practice. However, the point I want to make one more time is the following. How do you enforce a program like ERAS or a process like ERAS in a program? And that's why creating programs that are verified or certified by somebody in the United States is the American College of Surgeons, but in Europe may be different, in every country is different. But you gotta be on your toes all the time, doing continuous quality improvement and measuring your outcomes and measuring your consistency in the use of these protocols if you have external eyes on you. And that is what makes those protocols be successful. If you translate this, the trauma care experience to this, you will see that everything we've done in trauma so consistently, at least in the United States, is because we have a verification system. If we didn't have external eyes, we would be relaxed, and California would do different than New York, and Florida would do different than Washington State. And that's my point, is the enforcement. We can create any guideline. The problem is you implement and nobody follows, or you implement and you mandate because you have external eyes looking at you, and you may lose your verification or your certification or your accreditation, and then you are in trouble. So I think it's easier to implement things like this as part of a program than as an isolated initiative.
Okay, I think that's great. The take-home message from this has to be, it's great to have a protocol, but it's much better to actually implement it and use the protocol that you have. I'd like to ask the panelists one last question.
May I say just one question about this? I'm sorry.
Sure.
Yeah, sure. The question is just about protocol and using the protocol, because sometimes now we have a very many difficulties in Spain about the virus and the COVID. So when using protocols and we're using the recommendation, perhaps the aims is just not only morbidity or mortality, but some studies are just only looking for hospital stay. And we know in Spain a problem with hospital stay. On short-term, hospital stay is the best we can do now in our hospital, because we need beds in the hospital about this coronavirus and virus we are having in Spain. So this is a target we are looking for, just efficiency in our hospital, just not only mortality or morbidity, which is very much important of our outcome. But the other outcome before is hospital length of the stay. It's much more important now. We are fighting now in our society, in our Spanish group, working with this, not only in the elective surgery, but also as emergency surgery. Emergency surgery has only shown to be short hospital stay, but this is good for us in Spain now. Short.
I think it's a very valid point that the outcomes that you have to be things that are important. I'm not really sure how important it is to know how long it takes for you to pass first flatus after surgery, and whether that really is a useful measure. What I'd like to do is to ask the panel one last question, which is maybe a difficult one, but how would you answer a Viva question in examination about ERAS and emergency surgery? How would you tackle that if you were asked in a board examination? And I'm going to go for Raul again, because you are next to me on the screen.
So if I'm asked if I use it and how I use it, is that the question?
Yes, that's a reasonable question.
Yeah, again, I think I would say maybe I don't use it as I don't call it ERAS yet, because we are not organized yet to have it implemented, but I would emphasize what's important in the pre-operative period, what's important in the intraoperative period, and what's important in the post-operative period, and try to work with my critical care doctors and my anesthesiologists to get the buy-in from everyone to make sure that we consistently use those three components in patients with acute emergency conditions.
Okay, Professor Ramírez, would you answer differently?
I'm sorry, I absolutely agree. Absolutely agree. It's a team. It's a team. We have to have a team within anesthesiologists, ICU people, nurses, and so on. And we meet several times in emergency setting on warrant. So this is very much important to have a team.
And Dr. Mohseni, the last word from you.
That's actually an interesting question, and the answer should be obvious. When you look at the elective colorectal surgery, they have multidisciplinary teams. All attendings are there from oncology, radiology, and surgeons. And when it comes to emergency surgery patients that are both frail, they are presenting in a very bad shape, then suddenly this multidisciplinary thing gets lost at times. So it's very, very important to have everybody on board and load the boat with senior staff as soon as possible to get the best result from the ERAS.
Okay, thank you. I'd like to take the opportunity, I think, to bring this to a close. I'd like to thank everybody for joining us. We have a fabulous backstage crew without whom this would not have been possible. And I'd like to take the opportunity to thank my good friends, Alan Biloslavo, Hayato Kurihara, Diego Mariani, and Mauro Zago, my co-host, Aitor Landaluce, and our fabulous panelists, Jose Manuel Ramírez, Raul Coimbra, and Shahin Mohseni. I hope you've enjoyed this webinar and that you will join us again in 2 weeks' time when we will have an ESTES webinar on unstable pelvic ring injuries. And if we would also hope that you would then join us 2 weeks after that for a webinar on peritoneal resuscitation. Details of all future webinars can be found online on the events page of the ESTES website, which is estesonline.org. Hope we'll see you then. Thank you very much for joining us, and goodbye.